Well, welcome today. Thank you for joining the webinar. I'm Janet Gatlin with Rogers Behavioral Health. I'm your moderator for today's webinar. Joining me today are Doctors Renee Fung and Dr. Christopher Takala to talk about the intersectionality of identifying among those seeking mental health treatment. Before we get started, I'd like to give our participants a quick overview of today's format for the webinar. The webinar is scheduled for 90 minutes. To receive credits, CE credits, you will be logged in for the webinar for the entire program. This will be done via Zoom login, and the login records and the threshold is set to the account for the minor distributions of the internet connection. A PDF of the PowerPoint and the PowerPoint slides and a list of references will be available immediately today after the program via email with a link to your personal dashboard at cego.com. In addition to the recording of today's webinar, this will be published on the resource section of the website at our Rogers website at rogersbh.org after the presentation today. Our speakers will be presenting today for 70 to 75 minutes approximately. And then following today's presentation, we'll facilitate a Q&A session. I will ask our speakers a question. If you would like to ask our speakers a question, please use the Q&A section. And that's you'll see the Q&A button below. Please send me a message. At the bottom of the screen, you'll simply click the Q&A button at the Zoom taskbar. We will be reviewing all the questions that are submitted for today. Then the presenters will address as many questions as possible during the Q&A webinar portion of this presentation. Finally, there's closed captioning that is enabled for the program. At the bottom of your screen, there's a live transcription button. From the menu, you can click Show Subtitles to view all this as audio as text. If you'd like to disable the subtitles, then simply click Hide Subtitles from the live transcription. I'm going to go ahead and turn it over to our presenters. Thank you so much.
Hello, I'm Dr. Rayanne Hofung. I just wanted to say that Dr. Takala nor I have any disclosures to make today. Next slide. Here are the learning objectives for our session today. Next slide. And as you know, we'll be covering both the role of identity in diagnosis and the role of identity in treatment. Next slide. We acknowledge that our experience, intersectionality, privilege, and lack thereof inform what we each bring to our research, our clinical practice, and our teaching. On this slide, you'll see a variety of our professional and personal identities that inform the way we see the world. Next slide, please. All right, we're going to get started with diagnostic overlaps and the intersection of identity. We'll start off our talk today with a case study in an effort to be inclusive for people who may have visual impairments. I'm going to read off this slide. So here we go. Jasmine is a 16-year-old Black transgender female diagnosed with ADHD, oppositional defiant disorder, conduct disorder, major depressive disorder, PTSD, gender dysphoria, and cannabis use disorder. She has been psychiatrically hospitalized 9 times since 2017 to 2022 for aggression, suicidal ideation with plan with 2 attempts, and self-injurious behavior, which started at age 11. Jasmine is the 5th of 9 siblings, and she lives with her mother. She has a complex psychosocial history, including an unstable living environment, eviction, and witnessing interpersonal violence by her father, including the murder of her stepmother. Her father has been incarcerated since she was 5 years old. Jasmine has a history of engaging in sex work for money and currently has multiple sexual partners. She currently uses nicotine and marijuana with a history of trying other substances. Jasmine herself is concerned about her alcohol use and abstains. She was first hospitalized in 2017 after she threatened to kill herself, told teachers she hoped they would die, pushed a teacher, engaged in other physically aggressive behaviors in school, and generally did not follow school behavioral expectations. For example, she would leave the classroom. She began requesting to be identified as female during an early 2022 hospitalization. And during her second hospitalization that same year, she reported feeling good about living congruently. On the left hand of the slide here, you'll see just kind of a concise version of some of the demographic identity factors for this case using the addressing framework. Next slide. Janet's going to turn on the chat feature briefly so that you can participate in the next few slides here. I want us to start by refreshing our memories about the diagnostic criteria for several of Jasmine's diagnoses. So please do engage in the chat. The first diagnosis that we're going to talk about here has the symptoms listed on this slide. What diagnosis is it? Difficulty concentrating and learning in school, easily distracted, often doesn't seem to listen, disorganized, hyperactive, restless, difficulty sleeping. All right, I'm seeing the chat. Yep, okay. I'm looking off to the side because my chat is off to the right here. All right, next slide. I see a lot of people saying ADHD, and there were some people that were saying PTSD or trauma. Y'all are spot on here. So we know that young children who experience trauma may have symptoms of hyperactivity and disruptive behavior that resemble ADHD. Trauma can make children feel agitated, troubled, nervous, on alert, and those behaviors can be mistaken for hyperactivity. And what may seem like inattention in children who experience trauma could actually be symptoms of dissociation or the result of avoiding trauma reminders. Among children who experience trauma, intrusive thoughts or memories of the trauma may lead to that confusion or that agitated behavior, which again can resemble the impulsivity of ADHD. The research suggests that if both truly do exist together, we know that trauma can exacerbate the symptoms of ADHD and vice versa. Youth diagnosed with both experience higher lifetime rates of almost every other mental health disorder, and they also have more severe outcomes. Next slide, please. All right, here we go again. What diagnosis is it? Irritable, easily angered, temper loss, defiant, argumentative, easily annoyed. Please use the chat button to share your thoughts. Excellent. All right, next slide. Spot on. I'm seeing these flying in again. We know in the center here of the Venn diagram are the symptoms that are an overlap between oppositional defiant disorder and trauma. The research suggests that more than 800,000 children are exposed to trauma annually from just abuse and neglect alone. That doesn't include other criterion A traumas. And 20% of that 800,000 are observed to have dramatic changes in their behavior consistent with ODD following a traumatic event. That makes sense if we understand development. Child development. Children who experience trauma often have difficulties with emotion regulation, self-soothing, and experience distress when routines change, which can result in aggressive or oppositional behavior. Next slide. All right, what diagnosis is this? We have externalizing anger or aggression, reckless behavior, avoidance of telling the truth or lying, hypervigilance or sensitivity to threat. Please use the chat to share your thoughts on this one. Seeing a lot of people start to lean into trauma and PTSD. I think you're following where we're leading with this. And I am seeing some people who are mentioning one of the diagnoses that Jasmine had, which was conduct disorder. Next slide. Jasmine was diagnosed with conduct disorder, and here again, we see the overlap between conduct disorder and trauma symptoms. Researchers remind us that the aggressive behaviors common to conduct disorder span a broad range of severity. Can look like frequent bullying, threatening other kids, intimidating other people. Sometimes it can look like forcing people into sexual activity or engaging in physical fights, stealing, deliberately being cruel to people or animals, using weapons to cause harm. Notably, the diagnostic criteria for both oppositional defiant disorder and conduct disorder are simply checklists of behaviors without reference to cognition, emotional experience, or physiology. Kids with conduct disorder are thought to misperceive the intentions of others as hostile or threatening and then respond physically. This phenomenon is known as hostile attribution bias. The etiology of this perception, according to the DSM, really seems to matter not, which can ignore the potential context of growing up with family or community violence, rejection, physical or sexual abuse. From a trauma perspective, the perception of threat is reasonable if the child had gone through those experiences and could even be considered adaptive and necessary for survival. All right, next one. How about this one? What diagnosis is this? Again, please continue to use the chat to share your thoughts. Beautiful. I'm loving to see the engagement in the chat. Thank you. We can move on to the next slide. You're right, the symptoms definitely are symptoms of PTSD. What I want to introduce to you today is a model that isn't a diagnosis in the DSM, but it is definitely worth considering when we're thinking about identity and how it plays a role in our conceptualization and diagnosis. The minority stress model was developed to explain the health disparities in the LGBT population and has since been expanded to other gender and sexual minority identities. The minority stress model has three basic ideas. The first idea is that stressors are not distributed randomly in society. Rather, they're tied to social positions and processes. The second idea is that all other factors held constant, prejudice results in higher rates of psychological distress than in their peers. And the third idea is that excess stress results in psychological and physical health disparities. We know that our case study, Jasmine, identified as transgender. Some of the stressors that the research has identified that could lead to these symptoms include ongoing oppression and discrimination, microaggressive experiences, rejection, social cultural reactions to identity and expression. We see here again that there is significant overlap between the symptoms of minority stress and what we know to be PTSD. Next slide, please. What diagnosis is this? And this is the last one. So please use the chat to share your thoughts on what diagnosis has the symptoms of dissociation, anxiety, depression, sleep disturbance, hypervigilance, intrusions, avoidance, physical symptoms, changes in mood and cognition, inability to experience positive emotion, anger, low self-esteem, and I'm seeing them all come in again. And it's looking like most people are saying PTSD. Next slide, please. So you're right. Again, the symptoms listed on that slide are symptoms that could lead to a diagnosis of PTSD. However, I'm going to introduce a new concept to you that it's called racial trauma. Maybe not new concept to you, but it's a newer concept in the literature and in the trauma space in terms of a potential diagnosis. So racial trauma is the psychological injury caused by mistreatment of a person due to their race, ethnicity, or skin color. And this includes experiences of police harassment, distressing medical experiences, community violence, workplace discrimination, hate crimes, persistent exposure to racial microaggressions, vicarious trauma through the graphic media coverage of horrifying experiences, and so on. On either side of this Venn diagram are the major symptom categories for each diagnostic conceptualization. And in the middle are the symptoms within each that overlap. Whereas the DSM-5 has a 4-factor model for PTSD, Dr. Williams and her colleagues have found a 6-factor model to be most fitting for racial trauma specifically. And it's notable that some of the experiences that I listed that could lead to these PTSD symptoms might not be classified as a criterion A trauma. However, I argue that if it walks like a duck and it quacks like a duck, it's a duck. And so it's important for us to start considering either the diagnosis and or the treatment for these things, even if they don't line up with a criterion A trauma. I want to note that in that middle section, in that overlap, the research has shown that Black Americans report the bolded symptoms to be the most difficult to manage when reporting clinically significant symptoms of PTSD. And so that might be something to look for or ask clients about. And the italicized symptoms represent the strongest relationship between race-based traumatic stress symptoms and trauma reactions. Next slide, please. All right. Now we'll move into trauma prevalence and impact. Next slide. So we know in the general population of people using binary gender categories, over 33% of people experience a potentially traumatic event before the age of 16. And the PTSD prevalence in those who identify as girls is between 3 and 15%, and in those who identify as boys, between 1 and 6%. In the adult population, approximately 60% of adults experience a potentially traumatic event. Some research will say a number as high as up to 80%. And again, the prevalence among PTSD prevalence among those who identify as women is 8%, and among those who identify as men is 4%. Next slide, please. Once we start looking at the intersection of identity and trauma, there's a little bit of a different story here. So when we look at the LGBTQ population, the research consistently reports higher rates than the general population of trauma experiences, although it's really hard to land on a number because this population isn't often represented in the research, or this identifying characteristic isn't asked about when collecting data. That's why you'll see the PTSD prevalence range is really high. It's generally understood that the PTSD prevalence is much higher in the LGBT population than it is in the general population. But here's a range of between 1.3 and 47.6% prevalence for PTSD. And in the transgender and gender diverse population, between 17.8 and 42% prevalence. Of note, this population experiences added stress related to policies that fail to protect them from discrimination at work, housing, and public spaces. And current events will suggest that there is much more stress around this right now for people, or at least the stress is being made much more public and is in the media. Next slide, please. Here we take a look at the intersection of identity. Ethnic and racial identity and trauma, looking at the BIPOC population, which stands for Black, Indigenous, People of Color. First, we looked at Dr. Williams and Zare in 2022, had a sample of 97 participants, and they found that 47.4% of Black Americans met criteria for racial trauma, as well as 22.6% of Asian American participants and 50% of Hispanic American participants. In a review of the inclusion of racial and ethnic identity in PTSD treatment research, for those who were included in the research, which is another gap, as we know, Grau and colleagues found that around 9% of Black Americans met criteria for PTSD, 2% of Asian Americans, and 5.5% to 6.5% of those who identify as Latinx. And as you can tell, I'm talking about gaps in the research of including, and typically only these three major groups are included in the research. So we still have a long way to go in terms of including other racial and ethnic identities. On the right side of the slide here, you'll see the results of a study of a sample of 106 counseling professionals. In that study, 71% of them reported encountering patients with race-based trauma experiences, and the majority of them report that they have never had training identifying or treating race-based trauma experiences. And then lastly, in a study of PTSD symptoms in Asian American Vietnam veterans, Liu and colleagues found that racism accounted for an additional 20% variance in PTSD symptoms above combat exposure and military rank. Next slide, please. Here I want to credit Drs. William, Haney, and Holmes, as well as the National Center for PTSD, for summarizing the evidence of harms in their article in the PTSD Research Quarterly. So these next two studies were brought to my awareness through that article. This study here, the researchers found in a sample of 110 Mexican-American adolescents, discrimination predicted the development of PTSD symptoms, which were then correlated with alcohol and drug use, involvement in fights, and number of sexual partners. All of these health risk factors were noted in Jasmine's psych evaluations and were indicated as reasons for treatment. Next slide, please. In a sample of 100 Black women living with HIV, the researchers investigated the relationship between discrimination experiences and PTSD symptoms, and they found that gendered racial microaggressions, which means being, they define it as slights and insults that Black women experience on the basis of both being Black and being women. So it's that intersection of gender and racial identity. These women were those experiences were more predictive of both total PTSD symptoms and post-traumatic cognitions than either race or HIV-related discrimination alone. Next slide, please. Okay, I'm just bringing us back to Jasmine's case here, and a reminder, she identifies as a Black transgender female. She has a whole list of diagnoses. And next slide, please. And here I want to suggest an alternative explanation. Next, thank you. The overlap here that we've seen between trauma and many of the DSM disorders in Jasmine's diagnostic history has been well documented, and it makes intuitive sense. The evidence I've showed you so far today demonstrates the overlap with all of the above and symptoms of racial trauma and minority stress. The groups who are more likely to experience minority stress and racial trauma also have the most disparate rates or access, to every single type of resource in the country. This begs us to consider the social cultural context of our patients and to integrate experiences of minority stress and racial trauma into our conceptualization and diagnosis. If not, we risk preventing access to appropriate treatment for our youth at the earliest signs of trauma and stress, like preschoolers, who are diagnosed with ADHD. And this misdiagnosis ultimately contributes to the problem and loops the pipeline to prison, which is known to be the diagnoses of ADHD to ODD to conduct disorder to antisocial personality disorder. On that note, I'll turn it over to Dr. Takala, who will discuss how the brain is implicated in post-trauma symptoms.
Well, thank you for that handoff, Dr. Fung. I appreciate the opportunity to be able to present to you all and appreciate you all being here. What I will end up saying is that this is going to be a dramatic shift that we're going to be conducting. We're going to be shifting gears to really talk about the brain, neurophysiology related to the stress response itself. That being said, one thing I have to be able to mention is that many of the processes and pathways that we're going to be discussing are also prevalent in many disorders that Dr. Fung also alluded towards as well. So certainly many of this overlap, or many of the overlaps that we see in presentations with patients having trauma can end up affecting vast array of different responses within the body. So my disclaimer is I'm hoping for some grace from everybody. I'm going to do my best to be able to consolidate all this information and deliver it in a packageable manner. But it is very true that the brain is complex. Many of the things that we're going to be talking about are heightened and inhibited, and feedback is navigated through different mechanisms to affect certain circuitry. And we're certainly learning more every single day as research is progressing in our field. So I am not an expert. However, I have to take a moment to express some gratitude towards a colleague, Dr. Gregory Burrick. He is a clinical professor through the Medical College of Wisconsin, as well as an attending psychiatrist through Aurora. I had the great fortune of training him for a brief period of time when he was at MCW residency, but he's gone on to do great work. And one thing of which is actually the presentation that I am going to be sharing with you. So I owe much gratitude and thanks to him for allowing me the opportunity to share some of the information he compiled. So before we get into a lot of the circuitry of the brain, let's just take a step back and try to be able to remind ourselves about the stress response itself. Certainly, we've all been back in classes to be able to discuss the evolutionary standpoint of the stress response. Its purpose is that fight, flight, or freeze response. And if you think back to cave people days, right, if they ended up walking out of the cave to be able to see a saber-toothed tiger in front of them and didn't react to that, there'd be drastic consequences. So this is something that's biologically passed down through generations, programmed within us to be able to react to novel stimuli to ensure that we can survive and pass on our DNA to the next generation. But overall, the cascade of events that end up transpiring really prepare ourselves to be able to act, respond to threats, and again, help us survive to the next threat that will face us down the line. The components of this response are complex again, right? They're comprised of areas just randomly compiled into or separated into areas of the brain. And what I'll end up pointing out is the areas of the body as well. So within the limbic lobes of the brain, there's areas such as the amygdala, hippocampus, locus coeruleus, anterior cingulate cortex, thalamus, the hypothalamus and pituitary glands that end up influencing, inhibiting, amplifying messages from various areas of the brain. Cascade of events transpires that can also send messages down to the body through things like the sympathetic chain ganglion to affect the adrenal glands. But the take-home message is that almost every single organ system in the body is affected by this response. So to be able to highlight a little bit about this, I wanted to introduce you guys to a fellow named Sam. He was kind enough to be able to join us on this little endeavor to be able to understand the stress response. So to say thank you to him, we're going to end up offering him some cookies. See that Sam walks over. And unbeknownst to him, there's a threat behind him that lurks. Sam ends up reacting to this. Now, if we think back to Pavlov and classical conditioning, the roar, the threat of a bear is an unconditioned stimulus that ends up eliciting an unconditioned response, right? That startle response, turning around, facing the threat, trying to ascertain really what is happening so that some sort of reaction or compensation can happen to overcome this. And we can break this down a little bit further, right, to be able to understand what's happening within the body. And then afterwards, we're going to go back and try to understand some of the circuitry involved within the brain. So we have this fancy dancy X-ray machine to be able to blow up here and try to understand first the systemic kind of outputs or things that end up transpiring as a result of this response. So again, throughout the entire body, right, various things are affected by this response. If you think about the actions of different neurochemicals like norepinephrine and epinephrine, it ends up causing a cascade of different things throughout the body. So take for the heart, for instance, right? It will increase heart rate, increase contractility to make sure that we can pump blood to vital areas of the body to help with the response. In doing so, blood pressure increases. At the same time, right, we're going to need oxygen in all of our cells to be able to respond to the threat at hand. So you'll see that respiratory rate will increase, again, to help deliver oxygen to vital areas of the body. Now, the thing that's really fascinating within the body, right, is that there's built-in safety valves, for lack of better terms. And the body's built in a manner to be able to conserve energy where it's not needed and divert it to where it will be needed. So the gastrointestinal tract, for instance, it doesn't make sense logically to be able to spend a lot of energy or deliver blood to that area of the body in the midst of a stress response to be able to break down and digest food. Rather, we will divert that blood to other vital areas of the body that will help respond to whatever threat that is at hand. Hence, you'll see the delivery of blood to those large muscular groups, right? Even the brain to be able to respond to the things that are really going on. Now, to understand a little bit more about what happens prior to these end results, let's end up looking at the brain in more detail. So there's a lot of different types of processing that ends up happening. We'll first kind of talk about cortical processing and specifically a bottom-up approach. And this draws upon some research from ADHD, but it still, again, applies to really the stress response with trauma as well. The first thing that ends up happening is activation of sensory areas, right? So the sight of cookies elicits that stimuli that ends up going through the hub of the brain, the thalamus, that's interconnected to almost everywhere in the entire brain and sends projections back to the primary visual cortex. There, that's where you're going to be recognizing salient information. In essence, those things that are fast, large objects are the things we're going to react to. But keep in mind, this is one sensory input. There are other areas of the brain that also receive input through our other senses. So just a heads up, this will likely not be the last time you end up actually hearing that. But I hope that it just reinforces, right, that you're going to be receiving input from various areas of our senses. The sound that we end up hearing goes to the primary auditory cortex. And again, salient information, right? We're programmed to be able to respond to loud noises, high frequencies. And that information is then relayed to auditory association, kind of core areas of the brain. Coupled with this, right, if you think about it, if we have to be able to react constantly to threats and don't have memory of it, it's going to set us up for failure. So there's certainly going to be that opportunity to be able to incorporate memory into this kind of reaction too. So anything that is threatening gets coupled with this sensory input as well to lay down future memory or memory for the future so that we can react in a more coordinated, efficient manner to be able to stave off any deleterious outcome. The frontal lobe's also involved with this too. Now, this area obviously is involved with planning, decision-making, so that we're not just having uncoordinated responses to things, that we can actually plan and execute something in order to ensure our survival. So this approach, again, drawing upon ADHD literature, is really a bottom-up approach. So attention, right, from salient information causes a graduated or even a large stimulation, which garners more attention to be able to make sure that we can end up responding. Moving down to more of a top-down approach, we'll start with the frontal lobe. So important to note, areas such as the prefrontal cortex are primarily inhibitory through neurotransmitters like GABA. This helps regulate a variety of different things throughout the body, in particular attention. And this helps with filtering a lot of information. If you think about it, if we have to react to every single squirrel that is in front of us, we're not going to be able to pay attention to the information that is vital to us in order to be able to stave off some threat. This also ends up dampening different things through subcortical areas, in particular trying to make sure that we can focus and hear the things that are pertinent to whatever we need to do to react to a situation. The frontal lobes are also involved in regulating behavior, right? That's through areas such as the premotor and motor cortices, as well as subcortical areas of the caudate and cerebellum. Again, when it comes down to it, if we have to be able to just react to situations, instinctual behaviors end up resulting in sometimes that may not be the most effective route to really overcome the things we're dealing with. Furthermore, emotions are regulated by the frontal lobes. And what you're going to see, we'll talk about this a little bit more in future slides, but there's this balance point, right, of trying to be able to allow the functioning of emotions to occur, as well as the control or inhibitory influence of the prefrontal cortex. And having those have feedback mechanisms, make sure that we can ensure or compensate with different things that end up arising. So areas such as the amygdala, hypothalamus, nucleus accumbens, and brainstem are also regulated by the frontal lobes. Again, coupled with this is the need to have access to memories. If you think to traumas that we've all been through, we can end up thinking about quickly about the sights, the smells that are associated with those memories, and it can serve that adaptive functioning of overcoming stress and ensuring our survival later on. This can also lead to the concept of suppression. So that's our voluntary inhibition of memories, impulses, or desires. And at times of great stress, we might have to do so to be able to ensure that we're responding in the best manner. Drawing upon the ADHD literature, again, this is viewed as top down. So those things that are relevant to us create a desire for us to be able to garner more attention towards that subject in front of us. The downside for this is that this is very slow. So from an evolutionary standpoint, if we have a threat like a bear in front of us, in order to be able to enact this, we might end up being harmed before we can end up actually utilizing this. That being said, these days, right, with the lack of saber-toothed tigers, a lot of these mechanisms persist and lead towards a lot of the impairment, functioning, and suffering overall for our patients. Turn towards more primitive things like subcortical processing. So we bring back our friend the thalamus. So just as a reminder, this is the hub for sensory and motor processes throughout the brain. It connects the brain and body, so a vital superhighway, for lack of better terms, in the brain. It receives a lot of different inputs, visual stimuli. Can't forget as well, getting input from our auditory stimuli as well. Furthermore, right, it also gets inputs from different areas of the body, or I'm sorry, of the brain, including the amygdala, the caudate, the frontal cortex, right, helping achieve this kind of balance point in terms of responses to what we're going through. It also has outputs, in essence, everywhere. In particular, there's two structures we always want to reinforce for that balance again, the prefrontal cortex, as well as our friend, the amygdala. And we'll talk a little bit more about the amygdala. This area is really just that seat of fear and anger responses. It's primitive, but it can serve as a smoke alarm, right? When you end up seeing smoke or smelling smoke, there might end up being a fire behind it. So it also does result in a large cascade of events that can help elicit various structures and end results to be able to make sure that we are out of danger's way. So it gets inputs from various areas, right? Sensory systems through the thalamus, the inhibition control that can be afforded through the prefrontal cortex, and also ends up going to emotional memories through the anterior cingulate cortex as well. Outputs include the dorsal medial thalamus, which are involved with pain, attention, memory. We have all heard of the HPA axis, the hypothalamus, pituitary, and adrenals, in short, affecting, again, the brain and the body. The hippocampus is involved with those areas of memory. So when we are stressed or overwhelmed, again, we can end up laying down very, very important information through our memory that's very attuned and specific about the things we experience. Furthermore, there's neurotransmitters that are affected by these outputs, in particular, increased dopamine through the ventral tegmental area, as well as norepinephrine that can be increased through the locus coeruleus. So involved in all of these outputs, you can see there's a cascade, but this, again, draws upon all areas of the body to respond to a threat. At the same time, it's something to think about, right? When we are prescribing medications to people to alleviate suffering or decrease symptoms to help them make progress in therapy, we can inadvertently affect different areas of the brain. So within the ventral tegmental area, right, if we are treating with antipsychotic medications, we can decrease some of that response by blocking dopamine. And then also, right, through things like the locus coeruleus, we can try to be able to tamp down that response too by decreasing norepinephrine through various other medications. So bringing it back here, right, we have, again, this balance point that ends up happening, this interplay between the amygdala and the ventromedial prefrontal cortex. And in essence, we're balancing our reactive or instinctual kind of reactions to things that we go through and the rational mind itself. They're reciprocally inhibiting each other. So it's an important concept to be able to keep in mind. When the amygdala is more tuned in, charged up, ready to react, what we see is the prefrontal cortex decreases. As a result, you have the preponderance of the fight, flight, or freeze response. And with it, decreased inhibition, decreased voluntary action, and again, more instinctual or reactive behavior that ends up transpiring. Conversely, if we see that the prefrontal cortex is more active and the amygdala is less active, we're in that position of being more relaxed and rational. So we have more inhibition of impulses and more choice of action, which can contribute towards some of the benefits of therapy to be able to overcome this kind of interaction, as well as concurrent use of medications. Within the hypothalamus, there's multiple inputs, right? All these interrelated areas of the amygdala, the solitary nucleus, which is more sensory tracts, and the locus coeruleus. Outputs include the ventrolateral medulla, which ends up resulting in cascade of different information through the sympathetic chain ganglion, leading towards that body response. There's the lateral nucleus, which is involved with orexin. And that's an area of interest for research as well. If you see there is a close interaction with various neurotransmitters, of which multiple medications can target these areas. So in particular, the posterior thalamus with the stress response, ventral tegmental area, again with dopamine, locus coeruleus with norepinephrine, the raphe nuclei affecting serotonin, and the tuberomammillary nucleus affecting really that arousal kind of area. So again, like further expanding on the tuberomammillary nucleus, this does affect histamine, but again, through various areas, ends up affecting arousal systems overall. Moving on to the pituitary. So this receives inputs from the hypothalamus. I mean, in particular, this is the extension of the thalamus, or I'm sorry, the hypothalamus just being the end of those axons. To the posterior pituitary, that's going to be involved in oxytocin and vasopressin, that's involved in that stress response. And then if we think about the anterior pituitary, we talk about the ACTH, or corticotropin releasing hormones, that are a consequence of corticotropin releasing hormone released by the anterior pituitary. So moving on to the outputs, the anterior pituitary again releases ACTH, which exerts an effect on the adrenal cortex, resulting in the release of a lot of these different hormones, in particular cortisol, the stress hormone as it's known as, which can increase blood glucose, decrease inflammation, and also decrease the immune function. So if you think about it from an evolutionary standpoint, it makes sense that at a time of stress, when we have to respond and make sure that we're safe, we want to have the energy supplied to our body via production of glucose. And at the same time, we don't want to waste energy by trying to repair the body or decrease inflammation and have an immune response, since we may not live to be able to actually benefit from that. In terms of the locus coeruleus, this is primarily involved in norepinephrine release. It receives a lot of different inputs from the orbital frontal cortex, which is primarily inhibitory, the medial prefrontal cortex, autonomics from the brainstem, as well as the lateral hypothalamus. The outputs involve the cerebral cortex, right, affecting things like the amygdala, increasing arousal and vigilance, the hippocampus, helping out with memory, the cerebellum with coordination, the brainstem and spinal cord, which affect the sympathetic chain ganglion, leading to whole body response, thalamus, hypothalamus, inducing things like the cortisol response, even also affecting the tectum, which ends up affecting those areas of hearing and seeing reflexes and the ventral tegmental area. The VTA, this area is involved in releasing dopamine. It receives inputs from the amygdala, the cingulate cortex, hippocampus, prefrontal cortex, and has outputs through the mesocortical pathway, the ventral tegmental area to the prefrontal cortex, and helps with increasing attention, concentration, and cognition. So this is one area to be able to focus upon, kind of a sidebar conversation. It's an area that is affected by two different classes of medications in particular, right? Stimulants can be effective in addressing some of the areas of focus, concentration, attention, and cognition, so that they can be amplified through this pathway. And also conversely, by using antipsychotic medications, that can actually be dampened. So if you think about the side effects of those types of medications, we often clinically see that people can have, with use of neuroleptic medications, decreased attention and concentration, as well as even difficulty thinking. Even in terms of affect, we can see that blunted kind of facial features that end up really presenting itself. In the mesolimbic pathway, there's the influence of the ventral tegmental area to the nucleus accumbens. This is all involved in the reward kind of circuitry, motivation and learning. But also important to note is that avoidance kind of pattern. So this is something clinically that's really tough, right? When our patients are going through traumas, anxiety, a variety of different things, there's actually biologically a benefit to avoiding that stress that they're going through. It's just now at this point in time, those avoidance behaviors reinforce many of the difficulties that they end up going through. So if they can gain understanding, right, why this is such a rewarding pathway, hopefully that will end up encouraging them to be able to recognize the benefit of exposures to be able to overcome the things they're going through. Just to be complete, we'll talk a little bit about the raphe nuclei. This is involved with serotonin and releasing serotonin. It receives inputs from areas like the orbital cortex, the cingulate cortex, hypothalamus, in particular, the medial and lateral preoptic areas, and has outputs to different areas of nuclei. Now, there are about 6 altogether. The rostral portions are the portions that are higher in the brain, and that's involved with the cerebral cortex, as well as the amygdala, which actually can be inhibitory in nature. Also a site potentially where medications can end up affecting, as well as the movement through the caudate and putamen. The caudal nuclei, again, those lower portions of the nuclei are involved with the brainstem and spinal cord. Now, another sidebar conversation, recognizing that serotonin levels can be affected by antidepressant medications. The thing that also we need to appreciate is that all medications we provide end up exerting systemic change. So when it comes down to serotonin, where it's actually distributed throughout the body, 90% is actually in our gastrointestinal tract. 9% is on platelets involved with really clotting overall, but only 1% is actually located in the brain. So it makes sense when people take antidepressant medications that we expect side effects of nausea, vomiting, diarrhea. Just to, in essence, we have to override the system that's involved with our GI tract to start exerting effects in the brain itself. Something that clinically, if we don't inform patients about this, often these side effects will lead them to conclude that they're having some adverse effect of medication. We have to provide that education that people should expect this. And not only that, that it takes time for these medications to work, a good 2 to 4 weeks at a particular dose to actually see any kind of effect. So now let's just take a little step back and review some neuron basics. You see here we have a presynaptic neuron on the left and postsynaptic neuron on the right. Within the postsynaptic neuron, we have postsynaptic receptors that accept different neurotransmitters, and when they're activated, leads towards propagation of a potential and a firing of a neuron. In the presynaptic side, we see reuptake inhibitors. These are the sites that SSRIs, selective serotonin reuptake inhibitors, as well as SNRIs, selective norepinephrine reuptake inhibitors, exert their effects. Lastly, there's things like presynaptic autoreceptors that really just dampen a response that happens so that you don't, in essence, for lack of better terms, wear out the presynaptic neuron from firing too much. So let's put this together. We see a firing of a neuron, which leads towards the release of different neurotransmitters being accepted by the postsynaptic receptor, resulting in a neuron firing. At that point in time, if this is happening consistently over time, it leads towards growth and maturation of that postsynaptic neuron, which allows it to be more attuned to the neurotransmitter that's being released and easier ability to be able to fire later on. But now, after this has been going on, we still have an issue that there's neurotransmitters in that synaptic cleft. And where do they go from here? There's a variety of different ways they can end up being utilized down the road. So as was just shown in that presynaptic reuptake inhibitor, the neurotransmitter can be reaccepted into the neuron where it can be repackaged and utilized at a later point in time. The presynaptic autoreceptors can also be activated, taking some of that neurotransmitter to actually prevent any further release of neurotransmitter when it's not necessarily needed. It's basically a feedback mechanism to decrease firing and, again, to try to prevent a neuron from, lack of better terms, wearing out. Lastly, you also have the option that you can see that neurotransmitters can diffuse out of this area and actually get incorporated into our cerebrospinal fluid, or CSF. There, they can join basically the soup of what comprises the CSF. And this is including various neurotransmitters and other substances within that. But in essence, it does form a background level of different neurotransmitters within the CSF. What we can end up concluding is that higher CSF levels indicate more activity for various neurons throughout the body. And to try to be able to extrapolate from that, it can also lead towards a diagram like this involving really different catecholamines within the CSF. See here on the y-axis, that's the prefrontal cortex abilities that range from having low levels with more being distracted, disorganized, forgetful, and impulsive. But when it's doing well, those abilities include being focused, organized, and responsible. And on the x-axis, we see what happens to the arousal state. When it's low, we're fatigued. When it's moderate, we're alert, ready to respond. And when it's excessive, we see issues of being stressed. So overall, there's this cascade of different experiences that people have. And we can liken this to basically having a stress meter. So at times, right, when we are at low stress, we can still have little levels of norepinephrine and dopamine, which might actually lead towards distractibility, disorganization, forgetfulness, and impulsivity. Conversely, when we are overstressed, overburdened, having excess levels of different catecholamines, we see that people still struggle with things like distractibility, disorganization, forgetfulness, and impulsivity. They are stressed and overwhelmed. So now, this next portion, in all honesty, I'm hoping for some grace here. So this is putting all these things together. I've been practicing a lot for this, and I feel like I get about 50% of the time I can actually do this together, but we're going to try to bring Sam back to see if we can put all these things together and make sense of what happens with the stress response. So if you recall, right, Sam has this exposure to a bear. So he already has preformed memories, right, of what happened with this bear. Coupled with it, right, he ended up getting exposed to seeing cookies and having this dramatic reaction. So we're going to allow him to be able to walk here. right? He's walking along, and then before you know it, he's surprised by actually seeing the cookies right in front of him. That results in this reaction getting elicited, right? The memory of what happened in the past. So that unconditioned stimulus, right? Now it ends up influencing a conditioned stimulus. Seeing the sight of the cookies leads to a conditioned response. So now putting all of these things together, we're going to look at what happens in the brain to be able to understand from the moment of input to what we see in the output systemically. So within the brain, we end up seeing the conditioned response of seeing the cookie, which relays information to the thalamus, sending messages to the amygdala, which ends up sending a cascade of norepinephrine throughout the body, influencing the hypothalamus, which ends up increasing the arousal response, sending projections down to the pituitary, which affects ACTH, sending downstream effects to the adrenal glands that can end up affecting a lot of the stress response via release of the stress hormones of cortisol, norepinephrine, and epinephrine that ends up sending that cascade of events right to various parts of the body. Again, increasing heart rate, increasing contractility, right? And delivering blood where it needs to go, increasing breathing and delivery of oxygen to where it needs to go. Then also trying to conserve energy when it's not needed by preventing the digestion of the food that we ate recently and diverting that energy towards the large musculature of the body to be able to respond to the threat at hand. So that itself is the fight or flight response. Okay. I'm actually pleased with myself that I got through with that, but I think I need to take a moment just to be able to transition here again. So moving on from there, right? The take home for all the brain functioning, it's super complex. There's a lot of things that are going on, but yet we need to learn more. This next portion, we're going to be talking about pharmacological treatments, but here's the long story short. There are currently, even though this slide is busy, there are currently only 2 medications that are FDA approved for the treatment of PTSD. Furthermore, that is just for adults, right? Me being a child analytical psychiatrist, this is something that we have to be able to ensure that we are being open and transparent about. And the disclaimer here is not to say that medications do not work for PTSD, right? There can be support provided, and we'll get into that in just a bit. But we have to be open and honest about the current state of which we're at. Certainly, there is evidence to be able to support that SNRIs like venlafaxine and nifazodone can be effective. And then we start getting into various other medications, right? Whether it's antidepressants of mirtazapine and trazodone, and a blood pressure medication called prazosin or prazosin that have been used for insomnia and nightmares, right? Treating symptoms that correspond with not only PTSD, but various other disorders. There's even evidence to be able to show that mood stabilizers like topiramate can be effective in managing patients with PTSD and co-occurring issues of alcohol use disorder. But here's an important take home is that benzodiazepines is quite controversial, right? Clinical experience tells us that patients really do appreciate this medication or this class of medication because it does dampen a lot of responses. But that being said, right, it leads towards more avoidance patterns and may actually dampen a response to the therapy that is vital in overcoming many of the difficulties that people have. So in my humble opinion, this is a class of medications I try to stay away from when I'm treating patients with PTSD. It's true that agents can end up alleviating symptoms, but rarely induce remission. And at the same time, if we do end up embarking upon times of discontinuing medication, there's a substantial risk of relapse upon discontinuation. Most patients with PTSD receive some form of pharmacologic treatment, including antidepressant agents, anxiolytic or sedative hypnotic agents, and antipsychotic medications. So again, clinical experiences, and this is something that I have the great fortune and respect for colleagues like Dr. Fung. The work that they do through therapy is immense and beneficial to our patients overall. But I see oftentimes, right, just like in the case we described, people can end up getting on polypharmacy to address a multitude of different symptoms. And unfortunately, there can be unintended consequences for that as well. In particular, if we take one sample of Iraq and Afghanistan veterans, in 2011, over 8% of those veterans received 5 or more CNS acting medications. So the multimorbidity of mental health disorders and traumatic brain injury was strongly associated with CNS polypharmacy. I'll contend that that could be well-intentioned providers that are recognizing distress, recognizing the lack of evidence that we have available, but trying to alleviate suffering by using a medication. But unfortunately, that can lead towards deleterious outcomes as well if it's not closely monitored. So suicide-related behavior and drug and alcohol overdose were significantly associated with CNS polypharmacy. So it's important to note that's correlational, not causal, but still something important for us to be able to recognize. Okay. So I hope I make the case that there's many gaps in PTSD psychopharmacology or pharmacotherapy research. In particular, we need to be able to understand the intersection of different disorders and how it influences what we see through folks with trauma histories. The question remains is, what do you treat first? Is it the thing that people are describing to be more suffering? Is it practical considerations such as suicidality that we have to be able to treat first? Is it really sleep? Right? There's a lot of strong opinions that are out there. There's some guidance through different algorithms that are there, but certainly we still need to understand this more through research. And while polypharmacy may result in improvement in PTSD symptoms, it may also result in more side effects, and that may contribute towards patterns of noncompliance to treatment. I'm certain that you've experienced many people, right, that can end up getting treatment through a variety of different maladies. But the moment that they end up experiencing any untoward side effect, they may reject help, right, express their frustration. And the downside being is that they continue to suffer moving forward. So speaking of algorithms to treat PTSD, through folks at the Harvard South Shore program, they compiled a lot of different available literature to really generate this algorithm that I have on the right portion of the slide. Interestingly, one of the primary focuses that they have with treatment of PTSD is to help improve sleep. Later on down the road, that's where we'll end up discussing things like an SSRI. That being said, it doesn't exclude that people could have already been on an antidepressant when you're actually assessing sleep and considering options for treatment. Down further from there, again, it's treating symptoms, alleviating distress with medications through a variety of different classes of medications. But nevertheless, their conclusion is that the treatment of PTSD remains a challenge for physicians as well as patients. There needs to be, we need to learn more about the pathophysiology of this chronic and disabling condition and about the comorbidities with which it presents. Improvements in our understanding of genetics, the neurobiological underpinnings of PTSD, and the mechanisms related to each symptom cluster promise to add refinements to the current treatment strategies moving forward. So taking a little bit of time, right, to talk about some of the pharmacologic interventions. Some people are doing more research and trying to understand when you treat and what you treat with. And this is not trying to be able to promote one intervention, just to highlight how people are thinking outside of the box to address this need for interventions related to PTSD. So looking at the fact that people can end up having a trauma, people have thought about in the aftermath or shortly after that experience, trying to treat to prevent future development of PTSD. And that would be using medications like propranolol, an antidepressant called escitalopram, benzodiazepine called temazepam, and gabapentin. But these results have been primarily negative. There's also, in looking at the stress response, the thought of providing hydrocortisone administered shortly after exposure to a trauma And that has some evidence to be able to show that it may end up reducing subsequent development of PTSD symptoms. Morphine has also been provided to help alleviate suffering later on down the road, as well as eminently, but it's also been shown a bit to be able to reduce the prevalence of PTSD in injured survivors of trauma. Lastly, intranasal oxytocin can reduce anxiety, irritability, and intrusive recollection in trauma survivors. Some more experimental interventions: transcranial magnetic stimulation of the right dorsolateral prefrontal cortex has shown a positive effect, but there remains barriers to treatments like this, including insurance coverage and the fact that you have to go 5 days a week to be able to get these treatments, as well as sit comfortably in a chair and not move often. Cycloserine, a partial agonist of the glutamatergic system, in particular the NMDA receptor, has conflicting results. Cannabinoids may decrease PTSD-related insomnia, nightmares, and hyperarousal. Intravenous ketamine, another glutamate NMDA receptor antagonist, rapidly reduces the severity of PTSD symptoms. And there's also randomized clinical trials that support efficacy of MDMA in the treatment of PTSD, but currently the database is insufficient for FDA approval of any psychedelic compound for routine clinical use. This may be the developing portion or developing sector of treatment for PTSD that could be promising. So some practical considerations, right? One group of medication is often not enough for the treatment of all PTSD symptoms, leading towards symptom reduction and heightening the risk of things like polypharmacy. Many patients with PTSD receive off-label medications and may lead towards being over-medicated. So again, it's that whole well-intentioned, but perhaps misses the mark. Also, it's important to be able to note that we're, as providers, good at providing a medication, starting a medication, but oftentimes in clinical experience, I don't hear many times from patients that there are conversations about when someone will consider coming off of a medication. Again, expressing my gratitude towards Dr. Fung and her colleagues, my clinical experience in a trauma recovery program treating adolescents at Rogers Behavioral Health in Brown Deer is that much of my practice was deprescribing medications. We might have to be able to provide some medications to act, in essence, like mood glue, keeping people together while they're conducting the hard work through therapy. But what you see overall is that once they're able to acquire those necessary skills to manage the complex emotions and experiences that they have, that the reliance on medication ends up decreasing. So irrespective of the different mechanisms of action of drugs used in the treatment of PTSD, the final goal is always the same: reduce distress, reinforce the psychological defense system, and restore the functioning of the person. And with that, I can end up passing back to Dr. Fung.
Thank you, Dr. Takala. Boy, am I glad I didn't have to pronounce all those words. You can go to the next slide, please. I'm going to briefly overview the evidence-based psychotherapies for the treatment of PTSD. First here, we're going to take a look at the treatment of PTSD in adults. So the American Psychological Association in 2017 took a real deep dive into the evidence-based research that existed, and they reviewed all clinical trials for the trauma interventions on this slide. They ended up grouping them together into these following categories based on 10 factors. I encourage you to take a look at the APA guide. But they prioritized, of course, symptom reduction as well as adverse events as critical factors in their determination. They acknowledged with the emerging research that EMDR and narrative exposure therapy would likely move to strongly recommends. And as this is almost 6 years old, there's mounting evidence that might change some of the recommendations the next time they review. Next slide, please. Notably, when the APA panel was convened and reviewing the existing research to make recommendations for clinical practice, they found that the majority of the intervention trials for children had significant methodological flaws and very low strength. And therefore they, at that time, refrained from creating clinical guidelines for the treatment of PTSD in children. I owe a debt of gratitude to the National Child Trauma Stress Network. They're an incredible resource, and they have an impressive repository with information on about 39 different interventions available for treating child traumatic stress. When I was developing the adolescent trauma recovery PHP and IOP programs that Dr. Takala and I worked together in, I found trauma-focused CBT to be the most fitting for our population. It has an evidence base for 3 to 21 years, and there's some emerging evidence for even younger children. There's a lot of flexibility to meet the developmental needs of the child and to have the child process and express their experience in a way that's fitting for them. So it's not always verbal or written. The target population is quite broad. In the US, there's evidence for Caucasian, African American, and Latino patients. Globally, it's been proven to be effective in Europe, Australia, and Africa. There's an evidence base for diverse socioeconomic statuses and religions in urban, suburban, and rural regions. And you can see here that there's a list of languages that it's been translated into. Additionally, there's a version called culturally modified trauma-focused CBT that integrates cultural concepts common in Latinx cultures. So although APA was unable to make a recommendation for these reasons, among others, this was the modality that we used in our program. Next slide, please. As you know, this talk is about the intersection of identity. I think it's really important to point out the significant limitations noted by the APA. There is a limited number of studies in investigating the clinical effectiveness in underrepresented groups. So in the 2022 review of the inclusion of ethno-racial groups in empirically supported PTSD research, Grau and his colleagues identified significant limitations with inclusion and the reporting of demographic information. So at times it wasn't even understood what the racial and ethnic identity of the participants was. Of the prolonged exposure and cognitive processing therapy trials included, Black participants were represented at approximately twice the rate as in the general population, so we're doing okay there. American Indian and Alaskan Native folks and Native Hawaiian and Pacific Islanders were close to proportionally represented, and Latinx and Asian participants were underrepresented, and you can see all of that in this pie graph here. Of the EMDR clinical trials included, white participants made up over 73% of the sample, and 17.8% of participants' ethno-racial information was unknown. Next slide, please. In the LGBTQIA+ population, as I mentioned earlier, participants are very underrepresented in the research. The gold standard treatments were developed for criterion A traumas. And there's question if do experiences of minority stress, although we know result in symptoms that are very similar to PTSD, do they fit the definition of criterion A, and ergo is using a PTSD intervention then appropriate? Another thought is the deconditioning and habituation in these interventions is meant for situations that have a very low probability of being threatening. And it begs the question, can we say with certainty that this is the case given the current political and social climate for our LGBTQIA patients? And then similarly, are the cognitions truly distorted, or are they based on mounting evidence? These are all considerations when we're trying to determine if we should be using one of the evidence-based treatments for minority stress experiences. Next slide, please. Recommendations. So there are a lot of recommendations out in the literature. I would say in the last 5 years, we're seeing the development and attention in this area, which is really impressive. I mean, it should have been done a long time ago, of course. And I think we're lucky that we're living in a time where we can go to the literature and find some guidance. across the board, people recommend having inclusive paperwork. That's the first time clients and patients experience us, is when they're filling out an intake form. And so having space for their identities to be represented is the first step in helping them feel safe and included. Focusing on empowerment, self-control, and connectedness with community. Oftentimes, folks who have underrepresented identities are out of control of their environment and of the situations that and focusing on that empowerment can really help them improve in their symptoms, and connecting them with community, especially culturally congruent community. Of course, providing education to families and patients. Education is power. That's why I gravitate towards the CBT interventions, because it is all about psychoeducation. It is incumbent on us to provide that education to patients and families so they understand that their experiences are valid. The symptoms that they're experiencing may be linked to the exposure to discrimination experiences. My platform is we need to train all staff in culturally competent care. There's been a big focus on counselor education and psychologist education, social work education, and even the person who does the intake call. Even any person that is in the building that has the potential to interact with your patients or clients should receive this training. Of course, we should be always assessing patients for stressors and social determinants of health associated with discrimination. And I have some assessments on the next slide as recommendations. We should be asking about experiences of police violence and racial threats, immigration difficulties, workplace harassment. When people have lived a life where these experiences are so common, they may not identify them as traumatic or abnormal. It is incumbent on us to ask and then to help provide that education. And then, of course, we need to ensure true safety if we're assigning exposures. And the recommendation is that you assign exposures in affirming context rather than thought challenging. And what I mean by that is, if somebody has social anxiety, we would assign them to go to a local LGBT community center so that they're experiencing that exposure in an affirming context, rather than asking them to thought challenge the idea that maybe people won't accept them, because we're living in a reality where that could be very likely. Next slide, please. Again, here is just a list of assessments. I'm not going to go through each of these. I just want to point out that I'm really proud that Rogers is piloting the development of an oppression-based measure of trauma and stress that will go across all potentially marginalized identities. So it's the last measure on the slide here. So keep an eye out for that. It's currently under review. And then next slide, please. Just want to revisit the case of Jasmine. And share some updates. So she did complete trauma-focused CBT at our partial hospitalization and intensive outpatient programs, focused on the murder of her stepmom. She continued with non-adherence to medications and continued to use marijuana. She publicly started identifying as female and using her chosen name and pronouns. We saw decreased healthcare utilization. We celebrate the fact that her last hospitalization was over a year ago now. There's been a decrease in self-harm and suicidality, and increased quality of life, as evidenced by attending school and staying in her family home. She reports satisfaction with living her authentic identity. So overall, we've seen a decrease in symptoms, improvement in functioning, with still some struggles. And we always say it's progress, not perfection. We celebrate Jasmine today. Mm-hmm. Next slide. And I just want to end on this quote. We meet these kids in the present, and we start with what we see. We get stuck on the things they do and say, and we focus on managing their behavior. We get so caught up in the urgency and intensity of the current moment that we forget about the past. We're so concerned with making their behavior stop that we ignore the reason it exists. And I encourage everybody to dig deep and start to figure out the reason that it exists, because that's where the real magic can happen. Next slide.
Well, thank you. Thank you so much for this presentation. Now it's time to answer some questions. If you do have a question, please again, use the Q&A button. You'll see that at the bottom. It's not the chat feature, it's on the Zoom taskbar. We will try to get to as many questions as we have time today and as possible. We also will continue to combine similar answered questions. If we do not get to your questions, please feel free to go ahead and email at webinars@rogersbh.org, and we will follow up with you to try to answer your question if we don't get to it today. So let's go ahead and answer as many questions as we can, if the time allows. How would you approach CBT with children so young?
That's a wonderful question. That's why I love trauma-focused CBT, because it really does take the development of the child into consideration. We were able to do many beautiful things with our younger kiddos, including we had some of our patients choreograph dances. We've had them create comics. There's a lot of, I'm not a play therapist myself. I don't work with really young kids, but there are a lot of people who use play therapy and sand tray therapy. So really anything that you can do verbally, you can do in those other modalities to meet the children where they're at.
Thank you. Perhaps this is for Dr. Takala. What is the consensus on ketamine therapy for PTSD?
That's a great question. I think there is more research that's being conducted. So this is just my humble opinion about it. I mean, there's research that's been conducted to be able to show how it can alleviate symptoms of depression, alleviate symptoms of PTSD, affect suicidality. But right now, it is not the standard, right, to be able to utilize that. My fear is that there is certainly a market for those interventions, and have to bear in mind too about the monetary rewards that can happen by having those clinics too. So I think with everything, right, there's promise that can be there, but I can't make those recommendations until it's actually been verified and evaluated by a lot of the national bodies that evaluate this work.
Thank you. Next question. Thoughts about using acceptance and commitment therapy for trauma in these populations?
I love acceptance and commitment therapy. It is not on the list of APA recommended treatments for PTSD. I will say, though, that I have used it and integrated it into my programs to augment the evidence-based PTSD interventions. It is a beautiful way of helping people reconnect with their values, helping them diffuse from those thoughts. I always talk about dropping the rope, stop fighting with the symptoms, and let's get down to living life. And so we have the luxury, because we have our patients for 30 hours a week. We have the luxury of integrating some of those other modalities. And I have found it really useful and helpful. And honestly, helpful in supervising my staff who treat these patients as well.
And that's maybe a good segue into this next question. What is the best way to train staff in cultural competency? Is there a go-to model that you prefer, or any suggestions on training staff?
If I had the answer for that, it would make my life so much easier. I mean, it is so complex. We all have been raised in a world, in a society where these things are so implicitly ingrained in the way that we think. And so I try to model it in all that I do. I certainly, trainings like this, I'm doing for my staff. I try to approach it from a gentle perspective and an honoring of all people's lived experiences so that they feel safe sharing their stigmas, their biases. But I don't have a go-to place. I would say it starts with you getting curious and doing the deconstruction of your own identity and of your own biases, and then integrating it into all that you do. If you ever come to one of my supervisions or come to one of my trainings, it's ingrained. We don't have separate trainings for cultural competence. It's infused in everything that I do.
To add to that, something that I can personally say in my interactions with Dr. Fung is that my awareness for my biases has improved, right? Coming from Midwestern kind of area that was pretty homogenous for a background, coming here to Milwaukee, it was the first exposure to a very diverse patient background. And with that, there's a lot of learning that has to happen. But what I really appreciate, it's kind of dovetailing what you said, Dr. Fung, but having that courage to ask the questions, but really not having any judgment or criticism for answers, but really just instilling through leadership, right, that we should be curious, then we should be free and open to talk about this. I think that it's been really helpful for many people, including myself.
Great. One more training question, and this is in regards to, how would one get trained in TF/CBT?
What I have encouraged my staff to do is there's a really wonderful, affordable online training through MUSC. If you just search TFCBT online training, I think it's about $35, and it walks people through all of the modules. And so that would be a really good start. And then I would also say pairing up with somebody who knows TFCBT, who can provide that supervision. There are other ways, more official ways, if you just look up some training for how to do that, but it all comes with at least a year of supervised experience while you're actually implementing the intervention.
Okay, thank you. Another question is, someone had a question in regards to, what is MDMA?
So if you think about ecstasy, right, another drug of abuse potentially, but basically along those lines of like psilocybin, LSD, those kind of medications that can end up being hallucinatory kind of experiences, that they've been investigating more about how those kind of family of substances can end up impacting PTSD.
Thank you. This one is also a question around medication or pharmacological medications. Have you seen many individuals that have both PTSD and ADHD? If so, what medications have you possibly recommended? And this, I'm sure, could probably vary, but.
Yeah, so that's where it's difficult, right? I mean, there's a lack of consensus opinion about what to be able to do. And I think often we fall upon the clinical guideline of trying to do what is actually, or address what is impairing someone's functioning to a greater degree. So if you're not able to attend or focus on therapy, that's going to limit your ability to acquire those skills. So that would make an argument to be able to treat ADHD more aggressively to help the downstream effects of their ability to participate in therapy. If you're looking at evidence-based approaches for ADHD, gold standard treatment are stimulants, right? So trying medications in the class of Ritalin and Adderall are very effective. And oftentimes it's one medication that can be greatly beneficial for treatment of that illness itself. It may have some benefits in terms of treatment for PTSD, but that's also another area that needs to get evaluated further.
Thank you. How do you provide exposure therapy for racial and related traumas? And there's a second part to that.
I think that could be an entire webinar on its own. I would encourage anyone who has that question to look into Dr. Monica Williams' research. She has a website that provides all of her research, and she has a paper on culturally appropriate modifications to PE for African American or Black Americans.
Well, thank you so much. There are more questions. Unfortunately, that is all we are going to have time to take today for questions. So at this time, remember, if we didn't get your questions, please feel free to follow up on email us at webinars@rogersrbh.org, and we can follow up with you. Again, many thanks today to our presenters, Dr. Fung and Dr. Takala. We really appreciate you taking the time and sharing your valuable insights with us today. It was really a great webinar. Before we conclude, I'd like to ask that we share a few additional resources on the topics that our participants shared with us today. If we want to go ahead and share a resources slide, that would be great. I want to remind everyone that those of you who've met our required time commitments today, you will be eligible for continuing education credits within the next 30 minutes. You will receive an email link with a personal dashboard on it at cego.com. There you'll be able to access our presentation with the PowerPoint slides as a handout and a complete list of references. For those of you who met the time requirements today to qualify for CE credits, you will need to complete the mandatory evaluation form, So please go ahead and complete that evaluation form and download your CE certificate for this event. If you have any questions following this webinar today, please contact support@cego.com. Again, on behalf of everyone at Rogers Behavioral Health, we thank you so much for joining and participating, not only in this national webinar, but all of our monthly webinars. We really appreciate you taking the time and joining us today. And thank you for your support and help with your patients. Thank you very much.